From a young age, women are always taught to know about their fertility, yet half of infertility in general is also led by men. Why do we not talk about male fertility as much as women's fertility?
Men generally don't want to talk about it. You're not going to sit there down a pub and say to your friend, I'm having a bit of difficulty conceiving my wife and my sperm count's a bit low. You just don't talk about it. In a sense, it's a woman's job to have a child. Therefore, the natural blame is on the female side.
You are one of the world leading experts in men's health.
You have urologists like me, or andrologists as we're termed, who deal with men's health.
What's your thoughts on where the sperm count lies now?
So we kind of just assume that men are fertile, but the answer is they're not, and fertility does decline. And it's not just about sperm count, it's also about DNA damage and other factors. There is enough evidence about endocrine disruption and chemicals, industrialization may be a factor for the decline in sperm counts. Caffeine has been associated with DNA damage of the sperm.
And sauna use, does that harm sperm production?
It's not going to do you any harm to avoid these kind of situations where we're exposed to adverse temperatures.
Stress has a massive impact on our physiology. Do you talk a lot to patients about how to manage their stress levels?
Honestly, to a degree, but not really. Not as much as I should.
There's a lot of conversation around freezing sperm, and Chris Williamson has actually frozen his sperm at 36.
Sperm freezing is not something I would particularly encourage. I don't think that one can say that you're going to freeze sperm in your late 30s, because if you have a child at 45, then my sperm count might be much worse. We don't know that.
What's the risk versus the benefits of TRT therapy?
Testosterone in the form of TRT acts like a male contraceptive, so don't take it if you want to have a child.
Can men without treatment medication naturally increase their testosterone levels?
We can try it.
If you are a regular listener to the show, or Live Well Be Well, or this is your first episode you're listening to, I really want to ask just a very small quick favour. If you could please hit the subscribe button or leave a review, this helps the show more than you can imagine. It means the world to help growing this show, and you all know that I have a huge thing to want to hit 100,000 on YouTube this year, and I can't do that without your support. I really aim to bring you the best guests possible out there, and I pride myself in doing that for the show because it's so important. But to keep the guests coming, to get them to be bigger, and to bring more helpful information to your ears and your eyes, I really would love to ask you to subscribe to the show. Thank you. I am so excited for this conversation today. This is probably one of our most demanded episodes around male fertility and male health in general, actually. I was trying to think about where I start this conversation because there's been a huge discussion in the press. I read a New York Times article that was just released a couple of weeks ago all around male infertility and sperm count and endocrine disruptors. And I was trying to really think about where to start this. And I wanted to start it from a woman's perspective, which is from a young age, women are always taught to know about their fertility. We always have this ticking clock that we're always very aware of. Yet half of infertility in general is also led by men. So why do we not talk about male fertility as much as women's fertility?
So I think there are probably culturally, socially, I think men are less inclined, and we know men are less inclined to talk about their health or even go and see clinicians about their health. I think that's really important to put across, which is often why, if you look at screening programs, for example, colorectal screening programs or bowel cancer screening program, men's uptake is far less. So I think men generally don't want to talk about it. And then obviously not being a woman, it's very difficult to say what women talk about, but in the sense that you're not going to sit there down a pub and say to your friend, you know, I'm having a bit of difficulty conceiving my wife and my sperm count's a bit low. I mean, you just don't talk about it, and you tend to blot it away and put it aside. So I think that that's one aspect. I think also there's a political part of this as well. I think politically, men's or male fertility is not something that is talked about very much. It's not a high priority. It's not a cancer, but as we'll see, hopefully as we talk, we'll see the importance of it in terms of longevity and health in general. So I think that there is both the cultural issue about men being men. I think there's also the issue of politically it's not seen as an important aspect of our health, which it should be. And I think the third thing is also for women as well, as we were talking earlier, that women, in a sense, it's a woman's job to have a child. So therefore, the natural blame is on the female side. So people's perceptions are, well, it can't be me. And this perhaps an indication of perhaps our misogynistic society that we live in. So I think that there are those three aspects to it that are very important. So, and also education, which is the fourth aspect. There is a lack of education out there because of resource allocation. And as we said, the political climate isn't geared towards talking about men's health in general, aside from, obviously, from prostate cancer as well.
Yeah, I think it's really interesting because I think for myself as a woman in her 30s, women are always talking about fertility at this age. It's a very, very big conversation. For people that I know personally that have struggled to conceive, where actually it's not been about the women, it's been more on the man's side, it's become like a very big shock in those conversations. And it has interested me that we aren't talking about it as much. Men aren't really aware of this as much in their 20s, and maybe they only start to realize this when they have that moment to conceive. But you said something really interesting there, that it isn't just linked to conceiving a child, it's also linked to longevity. So can you talk about why this is so important in a general health term for men to understand?
Yeah. I mean, if we look at, you mentioned earlier a statistic of up to 50% of men or male infertility is due to a male factor. The issue there is that, yes, it is. And what we forget is that although if you look at society in general, yeah, we're geared up to have a child. So when you get married or you join somebody in partnership, one of your aims in life is to have a child. So it also comes as a shock when you can't have a child. So naturally, the end point to all of this is having a child. But what we miss in between all of this in terms of men's fertility is the concept of health. So if you look at health in general, we know that, for example, there are men with infertility, and we define infertility as the inability to conceive after 1 year of unprotected intercourse. You find that approximately 10% of those men can have no sperm in the ejaculate, which is very common, or more common than we think, probably 1% of the general population. But the more important thing about these patients, and we call them patients, is that ultimately they may have hormonal problems. 30% of men may have low testosterone, who have abnormal semen analysis. You also find an increased risk of testis cancer, partly due to endocrine disrupting chemicals and other aspects from childhood. But also there's a higher risk of other diseases, in particular metabolic syndrome. Metabolic syndrome is a cluster of cardiovascular symptoms such as hypertension, heart attacks, diabetes, and there's a higher risk of having these type of disorders, and we call it metabolic syndrome. And in fact, some studies, which are not great studies, but there are studies suggesting that men with infertility have a higher risk of mortality long term because of the link with testosterone and because of the link with metabolic syndrome, which I'm sure we'll talk about later. But I think the main issue is there are other diseases that clearly are important. So it's not just about evaluating whether you can have a child. It's also evaluating you for your general health because of all those factors. And so I think it's important that the message gets across is that it's fine. And we understand the end point here is to try and get you to have a child and take you on that journey. But within that journey, you have to look at your own health and the long-term health of not only yourself, because then if you look at it, you say, well, what about if I do have a child? What about I want to keep myself healthy so I can look after that child long-term? And because of those other risk factors we talked about.
So I'm really going to delve into later around testosterone. It's one of the things that you pointed out. You are one of the world leading experts in men's health. I want to know, what is one of the biggest misconceptions that you see about men's health and men's fertility today? What is the one thing that you wish that you could just
I think
down?
that the biggest myth is you can't do something about it. You can. There are various things, and I think this is the problem we have in two parallel worlds, because you have on one hand gynecologists looking after women. You have urologists like me, or andrologists as we're termed, who deal with men's health, looking after men. And often both those services and both those health aspects are not integrated. So what they should be is they should be integrated so there's an overlap and people talking. So one of the biggest problems we see is that when men go and see a doctor, invariably, if they can't conceive, it will be a gynecologist or an IVF centre. I think it's slowly changing. But invariably, they won't come and see a urologist like me. Because often people will say, well, you've got sperm there, we can use this for IVF treatment. But ultimately, there is a bigger picture, as we've already discussed, in terms of their health, and there may be other common causes that you need to exclude as well. So that's probably one of the most frustrating things I see
Yeah.
in clinical practice.
Well, I know that you said on the NHS waitlist you have a year for people to come and see you, which is long, especially this feels like, quite a prominent problem for some men if they're really wanting to conceive and having to wait a year. What's the most common problem that you see with males that walk through your door?
So in the context of male fertility, I mean, the waiting times are like that throughout the country. And I think that one of the problems is that we talked about women, and we talked about the biological clock. We know that female fertility declines after 35, 37, and definitely by 40. So the problem is that most patients are referred probably at that age because women are having children later in life now. As we know, birth rates have declined as well due to multiple factors. But my point being that one of the key problems we see is that there can be correctable causes, but you almost reach the point where the female partner may be above 37. They might have, for example, a varicocele or varicose veins of the testicle, which you normally might 7-10 years earlier treat that. But in a sense, you almost run out of time, and you then sending those patients onto IVF. So I think one of the biggest frustrations is because of waiting times, because of the lack of resource that we have, is actually being able to probably treat patients the way we want to treat the patients. In a sense, we have a kind of almost a time bomb. It's not just about NHS wait times, it's also about the fact that women do have children later now, and the fact that they don't come forward as quickly. Part of that is, as we talked about, education of men as well. And often it is people do kind of put it beneath the carpet and, hide everything. And actually the key message is, what I want to see is people coming forwards earlier and defining. Although we say infertility is defined as a year of unprotected intercourse, it should be 6 months really in a female partner of 35, because we know how important it is in terms of women's ovarian reserve at that age to try and get tests done, investigate, and try and impact upon treatments as well. So that's really the key, I think, to seeing patients, but it's got to be streamlined really.
So you mentioned there about kind of women's ages. I think there's always this kind of perception that men can have children at any age and it's all going to be fine. And women are way more aware of this kind of age, 35, 37, then you go into your perimenopause. Is it true? Because I don't know if this is true, but men who have children later have higher risks of having a child with autism. I don't know if that's true. It's something that I read. Is it as easy for a man to have a child as he ages, or is actually there very similar risks as women?
Yeah. I mean, similar really, and I don't think we discuss it enough, but after the age of 40, semen parameters do decline. But also the other thing that happens after the age of 40, well, just doing a semen analysis doesn't give you the whole picture of fertility. You could have a normal semen analysis, but you could have difficulty conceiving. And more where science as it's changed, I mean, we talk about more and more the concept of sperm DNA damage, for example, which is very important, which we've done some work on and others have done work on, where actually your DNA damage increases as you get older, above the age of 40, definitely by 45 and certainly above 50, which might have an impact on genetic problems. We don't fully understand or know this. And therefore, there are many, many causes of sperm DNA damage. So after the age of 40, yes, there are other factors. You can have a normal semen analysis, but we talk less and less about it. Perhaps from Charlie Chaplin, for example, who was 80 when he had a child. So we kind of just assume that men are fertile. But the answer is that they're not, and fertility does decline. And it's not just about a sperm count. It's also about DNA damage and other factors, lifestyle, other illnesses, which can impact upon fertility.
Because I think when people might go and get a fertility test for a man, for instance, they'll look at the morphology, so the shape of the sperm and the mortality. But we don't talk very much about this, the DNA fragmentation, which you've done a lot of work on. If somebody is going to get tested and it comes back, I don't want to say normal, but in quotation marks, that everything's fine, or maybe their morphology is a bit off and they're trying to do lifestyle interventions to get it back. At what phase should they look at this DNA testing that you talk a lot about?
It's a good question. So you could imagine, so-called unexplained infertility accounts for about 30% of cases of infertility. So if you look at unexplained infertility, probably somebody who has the normal semen parameters, partner has what we term as a good ovarian reserve. And in those kind of cases, you probably should be looking at DNA. And these are the type of patients that historically would just send for IVF treatment, but they may fail IVF treatments repeatedly. And actually then we go back and they come back and see us. And this is one of the problems about working in an integrated fashion, in a collaborative fashion with gynecologists, with IVF units, because then you can, of course, assess patients comprehensively. So if the DNA is raised, and that's one instance that you look at DNA fragmentation. So if you've got normal semen parameters and everything is normal in terms of the female partner, and you might want to say, well, okay, is there an underlying problem here? Other cases of DNA damage you might want to be looking at in terms of DNA damage in those patients who repeatedly fail IVF treatments or have miscarriages as well, because we also know DNA fragmentation can cause that as well. So it can also be a marker in terms of risk stratification for outcomes for IVF. Now, the data is difficult to delve into because the data surrounding all of this, there's very few prospective or randomized studies. Most of the studies we have are retrospective and patients are their own controls. And in many ways, a lot of people don't believe in the concept of DNA fragmentation. So DNA can also be due to nutritional factors as well. So alcohol, smoking, caffeine as well. Patients who are overweight as well. Studies have shown reducing weight reduces DNA fragmentation as well. And so there are many other environmental factors. And also DNA fragmentation can be due to our own body bacteria, something called microbiome. So rather than the concept of actual bacteria, which of course can cause DNA damage because they create chemicals called reactive oxygen species, which are thought to then damage sperm DNA. It's also the concept now is called dysbiosis. Dysbiosis is where you get an imbalance of bacteria and bacteria that we harbour. So normally may not be pathogenic or causing problems, but an imbalance has been associated with infertility. So there are many studies out there. We did a study recently at Imperial showing that there was an imbalance of certain types of bacteria. So we're not saying that somebody's got an STI or somebody's got, but actually these bacteria that we harbour can cause changes, inflammatory changes, which can affect the sperm and also affect the DNA damage.
As someone who has spent a long time studying the mind-body connection, I'm constantly asked, what do I use to track my health? Since April, you've probably seen, if you're watching this show, me wearing a piece of tech on my arm, and that is No Watch, because I genuinely believe it has been one of the most thoughtful and mind-aware pieces of tech that you can wear. Unlike most wearables that focus just on your steps or your sleep, No Watch is a bit different and gives you real-time insights into your nervous system, the invisible engine that calibrates everything from your stress to your sleep to your recovery, your rest, and ultimately your health. With its stress recovery metric, it doesn't just show you how long you were stressed for, but also how long you recovered. It shows you your homeostasis. And that to me is where real health begins. And I think it's all something that we're craving. And most importantly, it does this without dragging you back to your phone, because that motion just depletes you. It delivers meaningful health insights to you only when something genuinely matters, using AI to turn complex signals into clarity that you can understand. And in just 5 days, it calibrates to your body and creates your personalized health fingerprint. You can try it for 30 days completely free. And if you're curious, now's the time, because they're giving you guys 15% off with my code LWBW15 if you head to nowatch.com. And you guys know, as listeners of Live Well Be Well and this whole community, that understanding yourself in the most mindful way is one of the most powerful things that you can do for your health. And this little gadget helps you on your journey. Like you've mentioned lots of different lifestyle factors there, such as nutrition, your metabolic health, alcohol, caffeine, and obviously that's connected to DNA fragmentation, which you were talking about. But also this is, I guess, connected to fertility in general, things that are also really important to be aware of. Before I go and delve down too much in the nutritional side, which I find very fascinating, one thing that's very much come to mind in conversation in the last year that I wanted to ask you personally is saunas and sauna use. Does that harm sperm production or sperm quality? And does that impact fertility at all for men's health?
It's difficult to say, because if you think about it, how do you measure heat? How do you measure how often people are exposed to heat? It's quite a difficult problem to define. The answer is yes. So you want to try and avoid heat. I suppose the more pertinent question would be, hot baths, showers, saunas. yeah, it's not going to do any harm to avoid those, because obviously the temperature or spermatogenesis is very temperature sensitive, with the testicular temperature being about a degree below the body temperature and should be kept at that. But I suppose the interesting question is, what about a lot of you see out there, socially, about douches, cold douches, etc. Do they work? I mean, again, it's very difficult to say. And I think that ultimately it's about patients being happy. I've almost tried to avoid answering the question, but I'm not. What I'm trying to say is that I think the data about measuring temperature and measuring these lifestyles is quite difficult because it's quite variable. And that's really the difficulty. But it's not going to do you any harm to avoid these kind of situations where we're exposed to adverse temperatures.
Yeah, because I'm just thinking there's a lot of people that are very, into the side of longevity and health, and especially in the kind of the tech culture. And a lot of people will be going to saunas maybe every single day or every other day and doing a sauna for 10 to 20 minutes, maybe thinking that's having a very beneficial impact on their health. And cardiovascularly, yes, it is. And that's what research shows. But then on the flip side, is it also impacting their fertility?
Yeah. So I think there's a balance, isn't there? That's what you've got to achieve. And I think that's the difficulty. I don't think I can answer the question in many ways. The patient's got to make their decision as an individual. But ultimately, it's something to avoid historically and traditionally if you want to conceive.
So we mentioned something very early on, which is around the 50% decline in sperm cases since the 1970s. And that meta-analysis came out by Dr. Shana Swan. And then the World Health Organization kind of hit back at it and said, well, they disagreed actually that it wasn't conclusive. What's your thoughts on where the sperm count lies now with men's health? And the question I actually want to connect that to is, does it impact fertility directly?
As you know, this kind of data, and historically the paper before showed a 50% decline in sperm quality. We should call it more sperm quality rather than sperm counts, but we call it sperm quality. A meta-analysis is a good scientific way of collating data over time, looking at data, but it has its flaws, and it's very much dependent upon the quality of studies, which do vary. If you look at, I think, sperm counts overall, we've seen birth rates decline, but there are multiple factors. So I think one of the things about meta-analytical data, that all sounds very posh, but what I mean by evidence-based that you're using is it doesn't take into account some of these other factors we mentioned, social, cultural reasons, female age, for example. What is the true outcome, pregnancy rates? It's not just about sperm counts, is it? It's also about the female partner, ovarian reserve, etc., other pathological diseases that might be present. And so you've got so many other variables called heterogeneity within these studies that it's very difficult to say. But you should treat a meta-analysis for face value, and meta-analysis ultimately has gone through rigorous peer review, and therefore there is a reduction in sperm quality, but it would seem to fit with what's going on in terms of global birth rates as we know now. I mean, if you look at China, for example, people are now being paid to have more children or receiving financially, whereas historically it was the other way around because of the growth in terms of the population. So clearly something has changed over time, and there is enough evidence, as we talked earlier, about endocrine disruption and chemicals, industrialization, exposure to endocrine disrupting chemicals, which may be a factor for the decline in sperm counts.
So let's talk about the endocrine disruptors. So people might be wondering actually what that is, like what we're talking about. That seems to be, for me, looking at a lot of the studies where most of the research really sits, linking it to the sperm quality. Can you talk and let people understand what an endocrine disruptor is and what sits within that, and how people can actively try and make maybe changes in their lifestyle to reduce this?
I mean, there's a massive long list, and forgive me, getting old, I can't remember the full list, although I wrote about this, but the plasticides, pesticides, essentially plastics, which have estrogenizing effects within the environment. And these estrogenizing effects cause this dysgenetic testicle. And therefore, you then get these developmental changes within the testicle. How can you avoid it? With difficulty. That requires a social change in terms of industrialization, exposure, and occupational exposures as well. So that's a difficult one because it's almost, in a sense, about the environment and how we avoid that. So I think that's quite difficult. That requires political change more than anything else, right, as opposed to individual change, because we're all exposed to these.
Yeah. Do you think it's also about being aware of what we're putting on our bodies as well? Like, is it about using less chemicals in our homes, airing our homes more, choosing, I mean, I know that's a kind of quite a hard one to say, like choosing organic, because that's a very kind of elitist term that a lot of people can't afford that. But would any of those differences have any impact or not?
I don't think we know. I don't think there's enough data to show that. I think, there's definitely data showing the association with these chemicals, without a doubt, endocrine disruptors. But I don't think there's enough data, so in terms of preventative measures, how we can prevent this process, basically, or pathophysiological process occurring.
Right. And do you think that's one of the main reasons of the sperm quality that's lowering?
I think more and more it is, because it was originally described, testicular dysgenesis, by a Scandinavian doctor called Skackerback, who originally described it as a theory, and more there are studies ongoing confirming that. So I think that probably is at least one of the issues in terms of male infertility. I think there are, of course, multitude of other factors as well. Weight, increase in obesity throughout the world. Which again, we've got to remember that obesity itself can also cause not only problems in terms of cardiovascular health, but also fertility as well. So I think there are many factors. Types of food we eat, we don't fully understand or know any of this in terms of the exact impact of certain types of food. But if we work from the assumption that obesity is not good for your health and also fertility, then we assume that a lot of the chemicals that we're using, all the foodstuffs that increase weight, have a negative impact on your fertility. The other way of looking at it is it's not going to do any harm to lose weight or try and lose weight.
Yeah.
But studies, again, are interesting, aren't they, about weight? Because if you look at weight in itself, but on the other hand, if you look at, it's really fascinating. If you look at, for example, operations to lose weight, so gastric stapling operations, the impact on fertility is quite limited. You would have thought that losing weight and doing these type of operations, you would improve fertility, but studies are very controversial about that. What's more interesting, losing weight naturally. We did a study looking at an NHS diet, which interestingly improved semen parameters, potentially improving or reducing oxidative stress, which causes DNA. And it would be really interesting to see, for example, the drugs that are using the weight loss drugs, injections at the moment, Manjaro, etc., and their potential reproductive potential as well, and effects on testosterone. So I think that's a really interesting area that we'll begin to see evolve for the future over the next 1 to 2 years, and there will be studies looking at that and the potential effects of these weight-losing drugs on reproductive health, which will be fascinating.
That's really interesting.
Yeah.
Well, you mentioned a term that people might not be too familiar with, oxidative stress. And I immediately think of antioxidants, being a nutritionist here, which is basically why we get people to eat lots of fruits and vegetables. Looking at the nutrient profile to help fertility for men, women, I think we're pretty aware of what's important for our fertility. We'll look at understanding taking folate when we want to conceive, and CoQ10 could be really helpful for us. But I don't think men, and I might be speaking out of term here because I'm not a man, but are as aware of their nutritional status when looking at their fertility. I know that you've done a lot of research here. What would you recommend for somebody who wants to improve their fertility or their sperm quality, or in general, not testosterone yet, because we'll get to that. I think that's a separate conversation. How would you get them to look at their nutrient profile, and do supplements help?
Yeah, it's a really good question. Do supplements help? I think if you look at data, yes is the answer of individual studies, but you've got to then look at the quality of those studies, going back to what we were talking about, quality of science, meta-analytical data. So often we use meta-analysis to look at all of this. So if you look at meta-analytical data, you can drill down on certain, we talked about Q10, carnitine, for example, vitamin E, C, selenium, zinc. But what's interesting is, one of the best studies probably was called the MOXIE study, which was a Scandinavian study which is a prospective study, and one of the very few prospective studies of looking at sperm DNA damage and semen parameters, which actually showed no major benefit. But if you then take the whole data in meta-analysis, which is what it does, it looks at pooled data. When you look at a meta-analysis, there is a benefit for some of these. But the data, again, is what we would term as weak, because there's not that many randomized controlled studies looking at outcome. And in particular, you can look at data and it can say, we got an improvement in semen parameters, but a lot of the data isn't controlled. So you don't have a control group because semen parameters do fluctuate. So this is one inherent problem or variability in studies. And also at the end of the day, should you be looking at pregnancy rates or pregnancy outcomes? And there are analyses which are much more rigid, Cochrane analyses, which have shown some benefit of antioxidants in that setting. DNA is another issue. There is some evidence. Equally, there is, as we mentioned, that study, contradictory evidence suggesting the effects of antioxidants on DNA damage as well. But I think the problem underlying all of this is a lack of focus in terms of research and driving research in these directions, basically, because that's what you need, is you need more robust data to support practice. And I think that's where we lack that evidence base or science in the context of male infertility.
I'm interrupting for one moment to ask one small favor. Please subscribe to the show. This helps it grow more than you know. And I'm so bad at asking this from you. I'm so bad at thinking about this. But you know my goal is 100,000 to get to on YouTube. And I really want to bring you more content and better guests and bigger episodes. And we can only do that with your help together. So please do hit subscribe. Thank you. I'm thinking about people that want to try and actively do something for their health. As I'm hearing this, do you think people, because it doesn't feel like it's harmful with certain, I want to say multivitamins, but vitamin E, yes, it can on high levels be actually more detrimental.
Correct.
But thinking about risk versus benefits, if people wanted to dial down on looking at certain supplements to take or how they should be approaching their nutrient profile, what advice would you give?
I think the benefits outweigh the risks,
yeah,
as we know. And this, like you mentioned importantly about vitamin E, yeah. Okay, so I think that they do. So it's, you can say, and probably a nutritional pharmacologist would shoot me down, but I would say that the risks do outweigh the benefits. It's not going to cause you major harm. But I think the question, of course, is it going to do any good? Possibly, is all you can say based upon the data that we have. So if it's not going to do any harm, then it's reasonable to do that. I think nutritionally, it's important, because I'm talking to a nutritionist anyway, but I think it's important, the Mediterranean diet. I think it's important to lose weight, to exercise, and to do all these things are important. Stopping smoking, not drinking as much.
Caffeine?
Caffeine, very important as well, interestingly. And caffeine important for DNA, interestingly, which is a rather unusual thing to kind of pick out, because you kind of look at it and say, but again, caffeine, reduction or caffeine has been associated with DNA damage of the sperm. So, but again, you look at it and there must be some other biological factors or genetic factors as well, which might predispose, which is nobody's ever looked at, is are different patients more susceptible in their reproductive health to oxidative stress. That's one area which will be fascinating to look at. Is there an abnormality there? Because if you look at other people's lifestyle, because you always hear, don't you, that he was taking drugs, he was overweight, smoking like a chimney, drank lots of booze, and he managed to have 10 kids. And there I am with a waist of 32 inches, and I don't smoke, I don't drink, I don't do anything bad, and I can't conceive. So there's got to be other factors involved, not just environmental. There has to be genetic factors as well.
Yeah, I also can imagine within that, stress must be quite a big factor. And before I go on to the stress, I just want you to repeat those nutrients that you studied. Was CoQ10?
Coenzyme, yeah, Q10, carnitine, vitamin E, C, selenium, zinc. These are ones.
These are the ones to be really aware of. And I'm just thinking, if people are going to go and have a blood test, there are certain levels that they may be like. Is vitamin D a big player in this? I think that's quite an important
again, there's
vitamin
some evidence of vitamin D, isn't it? But it's a lot of these are animal-based studies as well, which is a problem, and therefore translating. We've got to remember, and that's one of the problems we have, actually. It's good you mentioned it, because if you look at animal studies, animals are more sensitive to toxins, animals are more sensitive to drugs compared to humans. So that's where it's difficult in terms of the translational science, in terms of extrapolating that to human beings, basically. So I think that those would be reasonable. Again,
Well, one thing that does deplete nutrients that I know, speaking as a nutritionist, is stress. Stress has a massive impact on our physiology. And I don't think that we look at it as acutely as we should when it comes to fertility. Do you see a lot of people walking into your clinic that suffer with high stress and that could be linked to fertility problems?
yeah, hugely. We live in a society that it's a busy world, and it's a busy society, and it's a society that doesn't take any prisoners, really. And I think that often people can't switch off, and often people can't stress. I mean, the nearest thing you can do, because you can't objectively measure stress in terms of fertility directly, that would be difficult. But take, for example, as part of the reproductive potential is erections or male erections. I mean, stress is a major factor for psychological stress for erectile dysfunction, for example. So in the same way, we've got to think physiologically about the effects. We don't know enough about stress and male infertility, but I'm sure it does have a role, without a doubt. But there are two aspects to stress. One is obviously you're trying for a child. You're not conceiving. It's stressful. It's difficult. You see and you look around you, people of the same age of you, and if you're in your 30s, for example, and you're going to christenings, you're going to weddings, and you see all these kids around you. Patients often talk to me about that and say it's one of the biggest stress, and they begin to slowly marginalize themselves socially from people because they don't want to have contact with children. That's really sad to see as well. And that's also what does happen. Then you look at the stress of a job. A lot of the time, people have very stressful lives, stressful jobs, financially, many factors, relationship issues. And the third thing, of course, is that relationship issue, isn't it? Ultimately, the way that fertility can impact upon the relationship with your partner as well, and how relationships can break down. And you do see that, sadly, in relationships. And so I think there are multiple components or facets to the stress. It's not just stress within the environment or the world you live in socially, but it's also about the process of infertility and what it causes, because it can have profound effects on relationships and people's well-being.
Do you talk a lot to patients about this aspect when they come through the door, on how to manage their stress levels?
Honestly, to a degree, but not really, not as much as I should. Because again, it's that kind of pressurized, isn't it? I mean, what we would want to offer is holistic care, but the trouble is that within the confines of restricted times, resource, it's very difficult. And also, we don't have that infrastructure. There are fertility specialists out there who deal with the psychological counselling and aspects of that, but more often, of course, is IVF units, for example, will have a counsellor who's really more talking about donor sperm, for example, and not talking about more holistically about the psychological well-being of the patient and how that's impacted and how that's affected. Because you do see it, you do this when you're in clinic, and you detect that stress between a couple, and it's not their fault. It's just they also need guidance as well. And I think we don't really deal with stress very well as a medical fraternity, and I think we should be, and we should have that resource as well, because it does affect people's mental health, and it will impact upon relationships, and at worst will result in people ending their relationships.
Yeah, absolutely. Well, I think it was really interesting going back to earlier when you were saying about women's kind of big markers of 35, 37 and 40, and egg freezing now has become very common among women, especially in their 30s. But now there's a lot of conversation around freezing sperm. And Chris Williamson, who's a big podcaster as well, has spoken openly about this, that he's actually frozen his sperm at 36. And I wanted to talk to you about fertility preservation. Should we encourage it for men as similarly as we do to women? And, what's kind of the outcomes? Because I'm quite aware of, if a woman freezes their egg solely on their own, there's less of a likelihood to get pregnant than freezing it with an embryo because of the thawing process. And then we have to see if the embryo connects properly. What's the risks versus benefits? Like, is it quite a high likelihood that if you freeze your sperm, you could then go into IVF? Like, what's your thoughts around this?
I mean, sperm freezing for, let's say, for lifestyle reasons is not something I would particularly encourage. I mean, it's individual choice, isn't it, really? If you want to do that and you feel more comfortable with that. I mean, the context of that we tend to freeze sperm in, for example, is patients preoperatively who are having certain types of cancer, chemotherapy treatments, where it's mandatory to freeze sperm in terms of the effects or the negative impact of these various treatments like chemotherapy, radiotherapy, removal of testis for testis cancer on sperm production. So that's one group of patients. The other group of patients may be that you're faced in clinic with a patient who may have a very low sperm count, because sperm counts can appear and disappear, that you might want to freeze. The concept of freezing for a man who gets older, I'm not sure that I would particularly advocate or believe that is something that I would say to patients to do outside of those indications that we talked about. I think it's about individual choice. If you feel happier doing that, fine. We know there is a decline, but we also talked about DNA as sperm. Preserving sperm at a younger age, fine. You might get better sperm quality in terms of DNA at a younger age than you would if you're older. But then we go back to what we were talking about earlier, and even pre-interview, about the concept of societal pressure. We tend to have children at a later age now. And, and society is moving towards that. And is this just a result of that, rather than a necessary indication to do that? I mean, I think there's different arguments about this, but I don't think that one can say that you're going to freeze sperm in your late 30s, because if you have a child at 45, then my sperm count might be much worse. We don't know that. But if it's something you want to do, you feel comfortable with that, then fine. But it's not something that I would be particularly going out there advocating.
Really? Okay, that's interesting. Well, let's go into testosterone, because I think that's a really important topic, especially for men right now. Can men naturally, without treatment medication, naturally increase their testosterone levels? And how should men be looking at this themselves?
Well, testosterone is important for cognitive health, mental health, argument about depression. It's also important, as we talked about, weight. We talked about cardiovascular disease and its association with metabolic syndrome, erectile function, libido. And there are many studies showing its association and the importance for general well-being. To try and improve it naturally, there are things you can do. I'm not a great proponent of so-called natural testosterone products. The evidence base for them is very limited. Data is very weak supporting them. But if you look at the concept of central adiposity, men who are overweight or obese have a lower testosterone because of this concept of testosterone conversion into estrogens, which might then impact upon the brain axis, which then reduces testosterone or other chemicals called leptins produced as well, which interact with that axis, causing something called secondary hypogonadism. But reducing weight, for example, natural weight reduction might improve your testosterone levels by 1 to 2 points or nanomoles per litre. But we've also got to then analyse, what do we mean by low testosterone? What is low testosterone? Because ultimately, you're not going to treat somebody who is asymptomatic, who doesn't have symptoms. But you might nowadays because of the associated metabolic syndrome. But men are normally what we term as hypogonadal. They have symptoms of hypogonadism, low testosterone, and also biochemical evidence of low testosterone. You should be treating both hand in hand. But if you look at guidelines vary about what levels you should treat, and that's really where it gets very difficult. So, and there are lots of kind of myths out there, but we formulated some guidelines for a guidelines group that I work for, and we said that if your testosterone is less than 8, and you have symptoms, you're definitely hypogonadal, you could consider testosterone replacement. 8 to 12 is borderline, and above 12, which is the total testosterone, then you're okay, basically. The problem is we've got this very grey group between 8 to 12, where people talk about measuring free testosterone as well. But I think if I got a patient who, for example, has 8 to 12, I'd probably be initially saying to them, look, we can try lifestyle modification in terms of losing weight, exercising to try and increase testosterone levels. Sleep as well is important, because sleep can also improve testosterone levels in studies as well. So, but then what comes first, chicken or the egg? Because testosterone can cause, as we know, problems in terms of sleeping as well. So you've got to weigh that up. So I think that there are some natural ways to do it, to answer the question in a long-winded way.
Well, I want to talk about a supplement that's going off, I think, a lot online right now, or the things that I've been looking at, which is Tonga Ali. Now, you just mentioned there total testosterone and free testosterone, which people might not know the difference between those two. But it's very interesting. There's a lot of people talking about Tonga Ali helping boost free testosterone by significantly quite a lot. Is it worth taking this? Is it harmful? What's the risk versus the benefits? And what's the difference between free testosterone and total testosterone that you were just
So
mentioning?
the first difference is total testosterone is the total amount of testosterone in your body that is bound to proteins, including something called albumin and SHBG, or sex hormone binding globulin. Free testosterone is that the body uses. It's free. It's within the plasma. So again, there's this whole issue about what's important is your total testosterone, your free testosterone, your total testosterone. Your free can vary. It's also very difficult to measure free testosterone bioassays as well. So I think if I was going to comment, and I don't know enough, in all honesty, about Tongali, nor would I want to comment too much, if I'm honest with you about it, Sarah. But I think that you have to be careful about data analysis and be careful about hype and careful about data that people, because that's what we've got to rely on, evidence-based, scientifically. If it's not harmful, fine. I don't see a problem in it. But on the other hand, I think we want to see more studies, more evidence-based, controlled studies. You want to see more science. That's really what you want to, and what I'd be saying to people about it.
So before we speak about TRT, which I really want to talk about because you mentioned there that actually it can be detrimental to fertility, this is a really interesting picture that I've kind of collated from speaking to a few people before this episode. And it's kind of in relation to testosterone. So men's roles are changing generally. Men are being told to be maybe more in their feminine, more connected to their emotions. Women are becoming more educated, are taking on more CEO roles. So, traditional roles are naturally shaping and shifting a bit, which is great. And if 3 people said to me before the show, is it because men's roles are changing in society that it's impacting their testosterone levels, and could that be impacting fertility? Which I just thought was a really interesting observation that I wanted to
I don't know is the answer to that one.
To put to you, really.
Possibly, but I think that there are. I mean, biologically, physiologically, there is testosterone is the kind of male hormone, isn't it? Really, I don't personally think there's enough data surrounding that concept, but open to any concept really nowadays to kind of explore it. So I don't think there's enough data to support that. But equally, we wouldn't have thought years ago about certain diseases and conditions that would be caused by certain things. So I think there's a lot to learn, isn't there?
Yeah, it was just a very interesting thought that if you're thinking about the drop in sperm quality since the 70s and how much men's roles are changing since then. It's an interesting thought to think, well, we're putting men more in their feminine as their testosterone.
Possibly, but then how does it affect testosterone? But yeah, sure.
So let's talk about TRT, because I think this is something that's been spoken about a lot online. When should people look at this as a treatment, and when should they not look at this as a treatment? What's the risk versus the benefits of TRT therapy?
Sure. I think one of the problems is about TRT is the concept. It is used more and more recreationally. Now, historically, and I think probably one of the negative factors about science is that we now know that testosterone has less harmful effects than what it used to in terms of exogenous or testosterone that's given either in injections or in the form of gels. I mean, we used to talk about the risk of prostate cancer, for example, where we now believe that it doesn't cause prostate cancer per se. Okay, so given it doesn't cause prostate cancer if you don't have prostate cancer. The other thing about it is that there used to be this issue of cardiovascular disease, a higher risk of cardiovascular disease, oddly, with testosterone, taking exogenous testosterone. We now believe from studies done that it doesn't. So it's become more and more acceptable that it's a safe treatment, especially now with more data emerging. We talked about metabolic syndrome and low testosterone association with longevity as well. So if we look at testosterone replacement therapy itself, there are various forms, but which patients are indicated? Well, I think that's if patients are symptomatic, that we talked about earlier, and have truly biochemical evidence of low testosterone. The group of patients we talked about, if your total testosterone is normal, above 12, you don't need testosterone replacement therapy. Because there's also this concept, isn't it, that people sell and say, my testosterone could have been 20 odd when I was in my 20s. It's now 12. That's halved, so therefore I need it. That's not correct. I mean, ultimately, it's about these thresholds and these values. There have been studies that have done that show what these thresholds mean in terms of symptoms. So testosterone, there are two different types. You've got to go back to basics. Two different types of hypogonadism or low testosterone. One is secondary, which can include late onset, which is late onset is the commonest one, the so-called male menopause, if we talk about that. So once you fall below the age of 50, certainly testosterone levels fall and can fall significantly. The other group is the primary hypogonadism, so men who have an intrinsic problem with their testicles, that might have had chemotherapy, radiotherapy, surgery, twists of the testicle, cancers of the testicle, where there's primarily a problem with the function of the testicle. So there's two different types. You've got to differentiate that. So it's important to see a clinician and differentiate that rather than just starting testosterone replacement therapy. You want to know, why is my testosterone low? And also screen you for other types of problems, like we talked about dyslipidemias, we talked about pre-diabetes or type 2 diabetes that can occur as well. So it's also important to look at all of that as well as lifestyle. So the type of patient that you would treat are patients genuinely biochemically with low testosterone who, after you've gone through a comprehensive testing and trying to differentiate the two different types. So those patients who have generally low testosterone with symptoms, and those are usually in clinical practice the late onset group of patients. In other words, the so-called male andropause or menopause as well. TRT generally is safe. There are some contraindications, for example, active prostate cancer, for example, patients who have breast cancer, which is very rare, patients who may have too much thickened blood, so-called polycythemia as well, and patients who may have heart failure as well. But generally speaking, it's a safe drug, which therefore means that one of the problems, of course, is it's often used as a recreational type of drug, that kind of image, social perception and concept of men, who are muscular and strong. And that's the image that people want. That's more of a societal perception and more the problem in terms of the media in portraying what is a male and an ideal male. And I think that's kind of one of the problems that we face, because we've got to remember, as you just said, that testosterone itself can have a negative impact on your sperm, exogenous. Although we need testosterone, paradoxically, intratesticular testosterone for your sperm production, testosterone itself, exogenous, inhibits the brain hormones called FSH, which drives sperm production, so suppresses it. So therefore, it acts like a male contraceptive. So this concept of taking it now, and that's kind of emerged and over many years, but we still don't fully understand the full cycle of that. And there are also various other types of treatment people have tried, of course, which we can talk about.
So I think anyone who hasn't had a child yet or is looking for fertility, it's really not a good idea to be doing TRT.
No, and although it's reversible in the vast majority, but in some patients it's not reversible.
Yeah.
Androgen abuse, as we call it, and a certain number of patients don't recover their axis. There are other drugs that people can use. Generally, patients who have hypogonadism or low testosterone, you can give things such off-label treatments, which should be prescribed by a specialist, I add as well, but often aren't, actually. This is kind of the gym environment. Drugs such as Clomid or HCG, which act differently. They boost your endogenous or your own body's testosterone rather than relying on an exogenous form. But exactly what you just said is that if you're thinking of having children, you shouldn't really be starting TRT or considering TRT.
Something I found really interesting when I was looking at testosterone levels in men is that testosterone levels seem to drop after men have children. And I saw a study that said men with the highest levels of testosterone were more likely to become committed partners and fathers, at which point they showed steeper drops in their testosterone than did their single childless counterparts. I found that quite interesting.
I haven't seen that study, but my comment would be that if you're in a relationship and it's a good relationship, invariably it's probably going to be a long-term relationship. And where I'm coming to is that if you've had kids, invariably you've been in that relationship for a while. So therefore you're going to be older. So therefore, is it just an age-dependent factor?
Yeah.
That testosterone drops, as we know, as you get older.
Yeah.
So if you think you're going to have kids, if we're having kids in our 30s, you might have a 10-year-old and 8-year-old, you're going to be in your 40s and your testosterone might be dropping. That's the way I would look at it.
That's really interesting, because I was thinking, is it the body saying no more children?
It could be. Biologically, it could be. We don't know enough, do we, about it? Why do women in terms of their ovarian reserve by 40 it's very difficult, isn't it? Why is that? Well, is it why should it switch off? I mean, that's really kind of an evolutionary discussion, isn't it?
Yeah, I mean, that's one question that
But it's an interesting concept because we don't look at it in men, do we? So
we don't look at it in men. I think everything around children and fertility is always anchored towards women.
Yeah.
And men just seem to, I think, it's just not conceptually spoken about at all. But I do think it is becoming now. I think men are becoming so much more aware of their health. They're becoming much more conscious of their health. And as you said, I think, looking back at the 1970s, people weren't having children later. And so now we're wanting to try and become more acutely aware of things that we can actively do that are, but as you said, also living in an environment that has so many more endocrine disruptors around us all the time. I mean, especially even living in London, in built up cities. I'd also find that quite interesting. I haven't listened to data for this podcast, but I'd love to know if there is reduced fertility rates in cities in more than rural areas.
Yeah.
Do you know if that's a thing?
I can't tell you offhand, but there are studies, which potentially show that.
What about America versus Europe? Because I also know there's more tighter regulations of what can get passed in Europe.
Yeah, and we talked to me about political and regulatory capacity. I can't tell you offhand about that either. But that's this kind of work we need doing, in terms of rural areas, in terms of, is it a first world problem or is it a third world problem as well? And we need comparative studies to look at that.
Yeah, because I know the regulations here in the EU are much, much tighter than regulations in America. And I know there's a lot of conversation right now, especially with everything that's happening over there, with people wanting to change that policy to make it harder, to make it similar to Europe, which will also have an impact on fertility. And that's the kind of wider issue that is out of the individual's hands when it comes to this, I think. So thinking overall, from a male who is listening to this, whether they're experiencing infertility, whether they're just curious about fertility for longevity or for children, what would you say is kind of the most important concepts for that person, this individual right now, to be taking away from today's conversation on how they can support their health in this way?
I think the basics of good health, basically. Eat well, live well, be happy, try and take out stress, exercise. We talked about Mediterranean diet. It's not to overindulge in alcohol, stop smoking, recreational drugs, don't take TRT as a recreational use. All those things are important. I think if you want to get checked, you should get checked. Don't be scared of checking. I mean, there are companies now that do home delivery kits for semen analysis. It's a bit difficult. If you say to somebody, look, you've got to go to a lab for a test, it's kind of embarrassing, isn't it? It's very embarrassing to go and have to do that. And so therefore, I think there are people, specialists, who can help you as well. I think that's really important to be aware of. And there are things you need to think about in terms of your general health. It's not just about your sperm count as well. So I'd be saying that get yourself checked out. You can do a sperm test very easily. Either you can get it online or you can go to a lab. There are many, many out there. But I think it's also putting it into context as well, of your partner's age as well. Make sure that you don't leave it too late. And, if you're thinking about kids, start early. And ultimately, it depends on your own lifestyle, but ultimately do get tested if need be. But it's not I don't think we should be scaring people into all of this. I think it's also about choice and people's choice. And and ultimately we do live in a society that we are older, and having children at an older age as well. But if you need testing, then go and see a specialist.
Yeah, and that there are things that you can actively do to make changes.
And there are things that you can change, and and empower yourself. Take control. And I think it is quite simple to do a sperm test. Remember, we said it's not just a sperm test. It's not the whole picture, but it gives you an idea of your fertility potential.
Suks, thank you so much for coming on to Live Well, Be Well today. I always leave with a final question, which I'm looking forward to hearing your answer with, which is, what does Live Well, Be Well mean to you?
Mine is a bit different, I think. I think to live well is to try and live healthily as you can. We all like a glass of champagne, and we all like to do things that are bad for us. And I think it's basically getting a balance. I think it's a balance of your own health and psychological well-being. You can't always be strict in terms of your diet. You've got to have some vice in life, and you've got to enjoy yourself as well, but get the balance right. And as long as you have insight into that and you can change that and modify that, then that's fine.
Yeah. Joy is such an important word, I think, in health today. So I'm really glad that you said that.
Great. Thank you.
Thank you so much.
Pleasure.